Hey, welcome everybody. I am back. It's Jane again with Y Senior Virtual Connect. Happy to be here today. A lovely day outside. It's nice to say that because it seems like these are few and far between lately. Um, but I'm here today welcoming back Cindy Hostetler, and she's with Care Weavers. And they were on in the very beginning when we started doing this. And their company really helps people, go through so many processes that you sometimes don't know you need until you don't have them. um, but today's topic is how to stay safe in the hospital, and things aren't the same in healthcare at all. So it's really kind of great to know, when emergencies happen, what you need to do. So, Cindy, thank you for being here with us. Just let us know what we need to know.
Okay,
Welcome.
great, Jane. Thanks for having me back. And I do want to talk today about how to stay safe in the hospital. My background, I am a professional nurse and a professional healthcare advocate. I've been in the healthcare field for my entire career, which now we're, I think, working on the fourth decade. That makes me sound really old when I say that. But my business partner and I, we know the healthcare system really, really well, and we know how to help people avoid delays, work through some of the red tape that exists a lot of times in the hospital, and get the answers that they need in order to make decisions and get ready to go back home. So staying safe in the hospital is tricky. It's probably one of the most unsafe places that you can be, frankly. And before we get started, I'm just curious with the folks we have here. We have Barbara, Janice, and Pinky. Is there anyone else on the line?
Yeah, Adrienne
Okay,
and Joanna are there. You just gotta move your arrow down. You can see the other
I
guys.
gotcha. I gotcha. Have any of you not ever been in the hospital before? Just say me. So all of us have been in the hospital?
Yeah.
Okay. All right. So when I start talking then about some of these situations, you'll probably be able to correlate it back to maybe when you were in the hospital and having that experience. Can everyone see my screen at this point?
Yes.
Okay. Okay. Um, Anyone want to guess the best way to stay safe in the hospital?
Not go. No.
Avoid going there.
Right. I was right.
And I say that with some level of candor, but it is also true. Granted, if we have any kind of health related chronic conditions or problems, the likelihood that we will be in the hospital at least at some point in our lives is pretty high. But outside of those kinds of things that are somewhat predictable, there are some things that we all can do to try to keep out of the hospital. Um, I wanted to just cover kind of the top couple of things right now that, particularly for older adults, can help us stay out of the hospital. I don't know if you all notice this or not, but I can notice it myself, and I'm just entering into my late 50s. But staying hydrated for me used to be really, really easy. I would carry a glass of water around, and I'd be drinking it all the time. And right now, as I get older, I find myself not necessarily being as thirsty. It's interesting because as we age, we tend not to notice thirst the way that we did when we were younger. And we also, our bodies lose the ability to conserve water the way that we did when we were younger. So anything that you can do to stay hydrated is always, always good. It can help prevent a lot of different types of situations in terms of your health care. We always, when we talk about preventing people from having to go to the hospital or to the emergency room, particularly with older adults, we are always talking about falls and how can you eliminate your fall risk or decrease your fall risk. Jane offers a lot of classes. There's all kind of classes out there on the internet that focus around leg strengthening and balance. Balance is a thing that tends to get worse as we get older. And sometimes people have chronic conditions with their inner ear that cause them to have disequilibrium and things like that. But setting up your home in a way that helps you to prevent falls, making sure that your floor doesn't have uneven surfaces, you have clear paths to walk to and from frequent locations that you're in and out of during the day is also helpful. A lot of times what we find with older adults, when they do fall, they have a higher incidence of a fracture just because of osteoporosis. And anytime you have a fracture, the likelihood that it's going to impact your overall mobility going forward is it gets higher as you age. Healthy weight and a proper diet. We can't say enough about good nutrition and maintaining your weight and exercising on a regular basis. Health and mind and body is important. Mind, meaning that we tend to increase our risk in developing dementia as we get older. And right now, the rate of dementia for Americans is on the rise. And often when I, volunteer for hospice, a lot of my patients right now, I think hospice carries a caseload of about 70% of all their patients that have dementia. Used to be other things like heart disease and cancer and things, but now their number one diagnosis is dementia. So keeping your mind healthy too is really very beneficial. Medications. This is a huge area of potential threat as well as healing. We as a society are very much medication oriented, meaning that a lot of times when we go to the doctor, we're expecting a pill or a capsule or something to help us get better. We tend as a society not to want to take responsibility for changing our health patterns and our behaviors. So we've become heavily dependent upon prescription medication. Advanced planning, I think, is the most important thing that you can do to stay healthy and safe in the hospital. And that may sound a little strange, but what I mean by that is make sure that right now, if you don't have these things hanging on your refrigerator, make it a point to try to get these things done within the next day or two. You need to always think about, particularly now with COVID, where they do have limitations on visitation, as well as people that can accompany you even to the emergency room or the urgent care. Oftentimes they prohibit having someone with you just because of the COVID risk. So it's important to think about who you want your primary point of contact to be for communication. And what I mean by that is, so let's picture this, you're in the urgent care, your point of communication, your friend, family member, spouse, whoever it might be, is either in the parking lot or at home. They're not physically with you, but you need to keep them in communication with what's happening to you. And you as a patient are probably really focused on whatever that accident or injury might be. So having that person on the phone when the doctors are in and out so that they can hear what's being said to you, as well as their ability to ask questions of the healthcare team is very, very important. So make sure you write that person's name down and their phone number, and make sure that you have a conversation with them and say, are you willing to be my point of contact in the event that I have to go, seek care, whether it's urgent, emergency room, or potentially be in the hospital. The other thing we recommend, and I've attached an example of this and I'll share it with Jane so that she can get it out to you, is just developing a short bio about yourself, high level stuff. What are your current conditions? What types of medications do you take? The dosage and the frequency. And then if you have any advanced care directives, such as a living will or a healthcare power of attorney, what we do is we recommend that you put that all into a Ziploc bag and you hang it with a magnet on the front of your refrigerator. You may not know this, but the refrigerator is the universal location for any kind of healthcare documents, not just in the United States, but in a lot of other developed countries as well. So if you have to call medic for any reason, they'll bring a team of folks in. Of course, they're going to focus on you first, but there's always going to be somebody else as part of the crew that's going to go look at your refrigerator to see what kind of documentation you might have there. If you don't have a magnet or something, the JCC is a great place to get them. They are called the Vial of Life. It's a big magnet. It's blue and white, and it says Vial of Life on the top of it, and they're free. They'll hand them out to you at no cost. And they've got some basic paperwork in there also. When we think about hospital errors, it's important to recognize how errors occur. There was a study that was published in 1999. It was called To Err is Human. And it was one of the first major studies that actually looked at what kinds of errors occur in hospitals. And the results of what they found through that research were fairly staggering. They were estimating hundreds of thousands of people that die because of hospital medical errors on an annual basis. And that paper and its publication was what really kind of put healthcare back on its heel a little bit and said, wow, we knew that there were errors. We just didn't know the magnitude of the errors. And most of the errors, if not all of them, typically are because we did not have good processes in place and good methods for communication. So that study kind of prompted a lot of introspective review. It promoted a lot of our healthcare quality organizations, such as the Joint Commission and the AHRQ, to start working with hospitals to say, how can we create processes that are efficient and help the clinician do the right thing and make it natural to do the right thing versus unnatural to do the right thing. So that was the start of all of this, what we call safety, no fail, organizational kinds of culture that we have in place today. And it's a work in progress. Healthcare is not perfect. Um, no industry is perfect. We'd like to get as close to perfect as we can, but that's why continuing to have what we call a known blame kind of culture is very, very important. And you'll find that if there is a mistake made in the hospital, oftentimes you are made aware of it. And the physician and the healthcare team are going to let you know that there was a mistake. And it's important that that come to the surface so that it can be studied. Medication errors are by far the number one thing that happens in the hospital. We estimate now that there are about 2 million hospital stays each year that have to do with medication errors. Either that could be drug to drug interactions that you're experiencing because maybe you are on so many different types of medications that we haven't really ever had a chance to study what those drug to drug interactions might look like being on so many different types of medicines. And your medicines can change. I mean, you're probably aware that with your formulary every year, my medications change. The medication itself might be the same, but one year I might be getting it from Merck. The next year I might be getting it from Moderna. And my pills are always kind of different. So as I sign up for a new formulary every year, it's important for me to at least start looking at my meds and saying, okay, this is what my lisinopril looks like, or this is what my Effexor looks like. So it's important for all of us to know what our medications are, why we're taking them. And when you're in the hospital, keep that thing in mind too. What are the medications I normally take? Sometimes they're going to have to be delayed or put on hold depending upon what is going on with you in terms of your condition. But we now have systems in place to help with the overall safety of our medication administration. And one of those is barcode scanning. Have any of you been in the hospital where they have used barcode scanning? So they put a barcode on your wristband, and before the nurse actually gives you something, they scan it just like a grocery scanner would work. Have any of you had that experience before? No. Okay. So what it means, and this is what's important. Before anyone ever gives you a medication in the hospital, you should ask them to do two things. First of all, you should say, please, when you give me medication, before you give it to me, would you please ask me to state my name and my date of birth? That's one check of identification. The other thing that they should do is before they administer your medicines, they should scan your armband. What they have to do is when they're taking the pills out of the bags in the cart that they use to dispense, they're scanning each one of those. So the scanner is actually correlating that this is the right drug, the right dose at the right time. What it hasn't done yet is it hasn't correlated that medicine to you. The only way it can correlate it to you is by the nurse scanning your armband. And if something isn't right, they're going to receive an audible and a visual alert in the computer system that's going to say, stop, don't administer this, something is not right. It'll actually pinpoint the exact medication that isn't syncing up for whatever reason. Could be the wrong dose, could be the wrong time, maybe it's the wrong patient. So those are two things that you can ask to be done anytime before your medications are given. And it's always good to look inside the cup, and nobody's going to take offense to that. Looking inside the cup and saying, can you tell me what I'm taking right now and what it's for? And if you don't recognize what's in the cup, ask the nurse what it is, and if it's something that you're going to be continuing to get on a regular basis. Infection control and prevention. Infection prevention is kind of top of mind right now for a lot of us just because of the coronavirus. And we're all hyper vigilant about hand washing, wearing our face masks, etc. That's even more important in the hospital. In the hospital, people are back and forth between different patients a lot. And hand washing is one of the most basic things that people can do to help keep themselves as well as their patients safe. So if you're there and someone walks into your room before they approach you and you didn't see them wash their hands, please ask them to do so. They are expecting you to ask them to do that. So don't worry about embarrassing anyone. Don't worry about talking down to someone about hand washing. If you haven't seen them wash their hands, please ask them to wash their hands. Again, making sure that people have masks on, and even when they do have masks on, making sure that they're keeping an appropriate distance from you when they're speaking. Obviously, they're going to have to get close to you in order to provide care or to do a physical examination. And I think we're getting better about this as far as wearing identification badges. Those badges should not only state what our name is, it should also list what our credential is: physician, nurse, social worker, speech language pathologist. So if somebody walks in your room and they don't have identification on, make sure you ask them who they are and what they're there to do and what their credential is. Are you here as a registered nurse? Are you a respiratory therapist? What exactly do you do here at the hospital? Another thing about infection control and prevention, any type of needle or tube that you have in your body, whether that is a urinary catheter or an IV or I don't know, maybe even a gastric tube of some sort. Think of those as highways for microorganisms. Think about little microorganisms walking down that tube from outside of the tube down into your body. They are a source of potential infection. And because of that, we in the hospital take a lot of time to make sure that if we do have a catheter in someone, or if there is a, hello?
I just muted Barbara, so.
Oh, okay. Make sure that if you have something in you, an IV, a catheter, whatever it may be, ask about it every single day. Doctor, is this still necessary for me to have this catheter in? And also make sure that someone is looking after that catheter every day, doing catheter care, cleaning it, making sure that it's not harboring germs. Doctors right now have to renew a urinary catheter every 3 days. Our goal is to avoid putting catheters in people unless it's absolutely necessary. And our goal is for short-term use only. Sometimes we will have conditions that require that some patients have to have a catheter in longer term, but getting that catheter out as soon as possible is going to keep you safer. Has anyone heard about MRSA before? Yeah.
Oh, yeah.
So MRSA developed basically because we have been careless stewards with antibiotic use. And what I mean when I say that is, again, back to the fact that we are a prescription medication driven society. That doesn't mean all of us are personally. I'm just making a stereotypical statement about our society as a whole. But we tend to also go to the doctor for a lot of things that don't even need to be treated for an antibiotic. Now, doctors have gotten better about this. Instead of just handing someone an antibiotic, If they think what you have is a virus and not a bacteria, a good doctor's going to say, look, I think you have a viral infection. That viral infection is going to run its course. Even if I gave you an antibiotic today, it's not going to hasten your recovery. It's not going to lessen your symptoms. It's actually more detrimental for them to give you an antibiotic than not give you one. And the reason for that is that over time, with increased antibiotic use, your body tends to develop resistance to the antibiotics to treat those organisms. And those organisms in your body tend to develop resistance to the antibiotic that you're being prescribed. One of the other things that can happen is you'll typically be given 7 days worth of an antibiotic. That's a typical cycle. And if you fail to take all 7 days worth of the antibiotic, what can happen is we may not kill the infection completely. And whatever is remaining of that bacteria, it has now learned how to grow stronger to avoid being killed by the antibiotic. So that's how this, I guess, multi-drug resistant organism that now exists in our society, which includes staph and a lot of other things, has come about. So being a good steward of the use of antibiotics, and if you are prescribed an antibiotic, making sure that you take all of your antibiotic. Those are two things that you can do that are going to keep you safer. Any questions so far? I'd rather have questions as we go along because I know it's hard to remember after we bypass the slide of maybe what you might want to ask. So I'll
And
just
Barbara, I muted you because there was some background noise, but if you have a question, don't hesitate to unmute yourself.
I have a question, Cindy.
Sure.
I have read some articles about that antibiotic use for 7 days.
Mm-hmm.
Isn't that, and they're right, it's not necessary for 7 days. It's used to all these years we were told we had to finish it. Isn't there something new going on or some new research that points in a different direction?
I'm not sure. I haven't looked at that recently. But I would say that's a good question for your doctor whenever they are prescribing it to say, you know, how long is the course of therapy that you think I need to take? And you're right. If that organism gets killed or dies off with just 5 days of treatment, you're absolutely right that they should only be prescribing it, because then all you're doing is you're just adding extra antibiotics to your system, which
Right.
can also build up resistance. But
Yeah.
I'll definitely take a look at that. I had not heard that.
Yeah. Okay, thank you.
Mm-hmm. Any other questions? Okay. Sepsis. I'm sure probably a lot of you, if not all of you, have heard the term sepsis or septic shock before. This has come about again for the same reasons that I just talked about. We tend to now develop these drug-resistant organisms, and they can harbor infections. And because they are drug resistant, they're very powerful. So sepsis is a huge problem that we have in our hospital systems, and it can be a problem even after you have surgery. So it's important that you pay attention to how you're feeling, how your wound looks, etc. The best way in preventing it is what we've talked about so far. Talking with your doctor if you do have chronic diseases. If you are advised to take vaccines, we recommend that you do so. And if you have concerns about any type of vaccine, to talk with your doctor about it and make sure that you're taking care of yourself as best you can if you have any kind of chronic health conditions. If you're in the hospital, there's some symptoms that you can be aware of. And the thing I always stress to people, whether you're in the hospital or you're at home, is that if you think something is wrong with you, it's highly likely that there is something wrong with you. And the reason I say that is nobody knows you better than you. So even if you're not feeling well and you call your doctor and they say, oh, I think it's X, Y, and Z, why don't you try this for a couple of days and see how you feel? If you are persisting in not feeling well and you're not getting the kind of treatment or attention that you feel like you need from your doctor, you need to raise a red flag and say, listen, I know how I feel. I'm not getting any better. I really think it's necessary for me to come in and see you. Same kind of philosophy in the hospital. And if you're sick, you may not even know these things. But if you have someone there with you, they may. There is now something called a rapid response team in a lot of our hospitals. And I do believe that both Novant and Atrium have rapid response teams. And what that means is that anyone, including you as a visitor, if once we're out of this COVID situation, or you as a patient, or me as a nurse, we can pick up the phone and dial that number for the rapid response team, and that will trigger an action where there are designated members of a rapid response team. It will always include at least 1 or 2 registered nurses. It will always include 1 or 2 physicians. And their intent, once that rapid response goes out, it's going to announce it over the loudspeaker in the hospital, and it's going to say rapid response to room 4915. And what that does is it immediately dispatches a crew of medical professionals to your room to figure out what's going on with you. They put that in place based on a true event that happened to a woman who was with her son in a hospital. And I believe it was in South Carolina. This happened maybe 15 years ago. Her son went in for just a routine emergency appendectomy. Post-operatively, she was in the room with him, and he continued to have a lot of pain, discomfort. He was very restless. This was done over the weekend, and it was a small rural hospital. So there weren't physicians just walking around the facility. And she became increasingly worried. And she kept going to the nurse and saying, something's not right with my son. This isn't normal for him. Can you please call the doctor? And this went on back and forth for a period of hours. Well, finally, when the doctor came in, he was bleeding internally, and he ended up dying as a result of not taking early enough action. And as a result of that story, and not just that story alone, there's probably events like this that occur throughout hospitals, you know, on an ongoing basis. But a lot of hospitals created what is called a rapid response team, so that there's a mechanism of action that you can take outside the normal talk to your nurse. Nurse, would you please call the doctor? It's a way to get highly qualified resources to your bedside immediately to see what is going on. And we encourage people to use it. If you feel like you're just not right, something just isn't right, it's important that you let somebody know and you get somebody in there to take a look at you and figure out what's going on.
I have a question.
Mhm.
Can you tell me exactly what sepsis is? My husband was told he had bacteria in his blood.
Mhm. That is what sepsis is. It is called septicemia. Emia equals blood in Latin, and sepsis equals infection. It is an infection of the blood.
Thank you.
And what will happen with that, if it's not treated, that infection of the blood, your blood goes through all of your vital organs. And what happens if it's not treated is you will start to see your vital organs, your heart, your kidneys, your liver start to shut down. So it is a life-threatening condition. And right now, I know for a fact at both of our hospitals here in Charlotte, Novant and Atrium, they have sepsis alerts built into the computer system. So the computer system is actually looking at an algorithm, and it's complex. It looks at your heart rate, it looks at your blood pressure, it looks at your state of consciousness. And if all certain factors add up into an equation to equal a certain quantity, it's going to flag it for the nurse and say, this might be an early sepsis patient. You might want to go and check this patient out. And then she's going to take action, or he, based on that early alert, and they're going to call the physician to say, hey, this patient might have early sepsis. And then there's a whole protocol of what they do to rule out or rule in sepsis. And then they take action based on that. Other questions? Okay. Can't seem to get my screen to move. There we go. Errors in surgery. This can occur, and this is scary. This little graph here is just representative of orthopedics. It was a study that the Agency for Healthcare and Research and Quality did in 2019. And I brought this up just to show you and present something visual that some of you may be shocked at. You know, in 60%, almost 60% of those cases, an orthopedic surgeon operated on the wrong side of the body. If any of you have ever had surgery within the last 10 years, probably to have a knee or a hip replaced or a shoulder, one of the things that a good surgeon is going to do, and if they don't do it, you should ask them to do it preoperatively. They're going to say to you, Barbara, what are you here for today? And Barbara's going to say, well, I'm having my knee replaced. And that doctor should say, okay, which knee are we replacing for you today? And Barbara's going to say, my left knee. And when they say that, that doctor's going to, you know, remove the blanket from your leg, and he's going to point to the leg, and he's going to say, point to the leg that you're talking about that we're going to do surgery on. And when you point to that leg, they're going to put an X on there with a magic marker. And that's one of the things that came out of that study about how to prevent, you know, wrong side surgeries in the OR, was by verbally having that collaboration with the patient and visually marking an X on that side of the body. Scary stuff, huh? Before you go to the hospital, if you're having elective surgery, it's really important that you do a little bit of homework to find out what the hospital's outcomes for that type of surgery are and how your surgeon does with that. And I can give you, I have a list in the back of this presentation of some sites that you can go to where you can get that information for free. It's important you talk with your doctor, obviously, about the risks and the benefits. And also what happens if I don't do the surgery, because, you know, electives are optional. And you have the right to decide when or if you want to have that surgery done. What I find with surgeons is they tend to underestimate how long it might take someone to recover and what kind of assistance. I see Barbara smiling. What kind of assistance you might need as you recover. So it's important to really kind of, and this is most often done in the office, say, now look, doc, give me the real lowdown here. If it's going to take me a good 8 weeks to recover from this, I just want you to be straight with me. And oh, by the way, I live alone. So what does that mean for me? Do I have to get somebody to come and stay with me for a couple of weeks, or what kind of care am I going to need? And then pre-op, I always try to encourage people to schedule their surgery early in the week. Friday is not a good day to have surgery. I know we all believe in the hospital that things run the same on the weekend, but they don't. Some departments aren't in. Doctors are rounding for their practice, which means I can tell you in the case of when I was still working at Carolina's Medical Center, Sanger Heart and Vascular, those cardiologists sometimes on a Saturday and Sunday were seeing up to 60 or 70 patients. Because their partners are all off. So they just want to pick up that load so they don't have to do calls so frequently. And that's a lot of people to see on a Saturday or Sunday. So we always encourage people to do it early in the week. That way you know that those resources are going to be there, and hopefully your doctor is going to be there too. Because if your surgeon does your surgery on a Friday, they may or may not be covering the weekend, but you always want to try to do it early so that person that did your operation is there and you can reach them. Meet with the anesthesiologist. That's pretty key. That usually happens without having to ask them, you know, about the type of anesthesia that you're going to get. And if you've ever had a negative reaction to anesthesia, and that could be something just as simple as ongoing nausea and vomiting, that is really important to bring up to an anesthesiologist, because there's things that they can do during the anesthesia and surgery process to prevent that from happening on the back end. And that's a horrible way to wake up from surgery when you're sick in your stomach and you're vomiting a lot. And I always want to know too, who's going to be in the operating room. A lot of times with joint replacements or new devices, sometimes the physician will want to bring in the device manufacturer and the salesman. And you're allowed to say who you want or don't want in the OR. So it's just a good idea to ask about that. When you're done with surgery, the surgeon's always going to come out into the operating room waiting room. And now that's really not possible either because of COVID. But what they typically do, they'll talk to whomever you've taken with you or whom is your point of contact. And they're going to say, Jane's surgery went really well. We were able to replace her knee. She had minimal blood loss. She's on a pain pump right now. We're getting ready to take her up to the recovery room. Once she's recovered, she'll go to the floor, blah, blah, blah. They tell them that, but you're there recovering and you don't hear that report. So it's also important when you are cogent and to yourself and your anesthesia is worn off, that you get a very detailed explanation of the surgery and have the chance to ask questions about how things went. Did everything go as planned? Is there anything that you encountered that you weren't expecting? The other thing is, while you're in the hospital recovering, it's no time to be stoic, right? If you are not feeling well, and I don't care what that means, I'm nauseated, I feel weak, I feel like I'm going to pass out, my pain isn't being well managed, I feel like I have to empty my bladder even though I went to the bathroom already. Please, please, please make sure that the staff is aware of what's going on, because it could be a very subtle sign or signal that there's a complication, and we want to know that right away. Unsafe injection. Anybody have any questions about surgery? Anything we didn't talk about? Okay. Injections and blood transfusions. This most often happens because of labeling problems. Sometimes manufacturers don't do a great job of labeling something that maybe was intended as a tube feeding to go into your belly versus an IV to go into your vein. Or we have a lot of drugs sometimes that look alike and sound alike. Or we have abbreviations for medications that are considered unsafe. The Joint Commission, which is one of the healthcare accrediting agencies, had put in place many, many years ago requirements for hospitals around how to appropriately label medications for injection and how to appropriately label things that avoid abbreviations that are unsafe because they can be mistaken for a different abbreviation. And they also introduced, the Institute of Safe Medicine Practices also introduced what they call tall man lettering. So what that will mean to a clinician is, if I have a medication that looks alike in terms of how it is written to another medication, they will distinguish it by making some of the letters capital letters and other letters small letters. So it forces you to take a different look at that and say, is that really digoxin that I'm supposed to give? So I'm just making you aware that they have built in these safeguards around medications. But again, injectables can also be scanned, just like the cup of tablets that that nurse is going to bring to your bedside. So before anyone gives you an injection, they should also be asking you, can you tell me your name and the date of your birth? And also be scanning your armband before they give you anything. Blood is a little bit different. People can have reactions from blood. They can have allergic reactions from blood, and they can have other reactions that are more serious than allergies if by some chance somebody hangs the wrong type of blood for you. So therefore, hospitals always require an additional consent be signed for blood transfusions. So you will have to sign that, and that means that they will have to inform you of why they're giving you blood, and you'll have the ability to ask questions. They should also be talking to you about the symptoms of an allergic reaction, which are fever, chills, nausea, vomiting, itching, tingling, just a sensation that doesn't feel right to you. So make sure that they're doing that, and make sure that if you are getting a blood transfusion, you're just paying attention to how you feel. And if you feel anything at all different, no matter what it is or how corny it may sound, make sure you call the nurse and let them know, hey, my tongue feels funny. I can't really describe how it feels, but it just feels funny to me. That's a signal to them that something's wrong. They probably need to stop the transfusion and check to see if you're having an allergic reaction. Research hospital outcomes. This is just, I know you can't read it. It's not intended for you to read on the screen, but this is one of the places you can get information if you are considering having surgery or if you have to be admitted to the hospital for elective procedures. The Centers for Medicare and Medicaid Services, they publish this information and it's available to the public at no charge. Any hospital, um, any type of rehab facility, long-term care facility, hospice care, any of those places that take Medicare as a form of reimbursement are required by Medicare to submit their outcomes to Medicare on a quarterly basis. And those outcomes get published, just like you see right here. And it allows you as a healthcare consumer to go out there and select different hospitals that may be within your network, and you can do a side-by-side comparison to see how they rank against another hospital. So this is just one screen that I pulled up. This is infection-related information, and I'm comparing the first hospital here is Novant. The second one is Caramount, which is down in oh shoot, it's in South Carolina, Gastonia, is that right? Yeah, Caramount Health. And then the last one here is Carolinas Medical Center. And again, you can compare people side by side and just see how they rank before you make decisions about where maybe you want to go to get your treatment. So again, keeping in mind that we have really fragmented healthcare systems. And if you're in the hospital, the likelihood that there's only one physician taking care of you is non-existent. There's always at a minimum going to be two. With the advent and the introduction of what we call the hospitalist, this is a person that works within the hospital. They tend to work 12-hour shifts, 7A to 7P and 7B to 7A. And what their role is they are one of the people that help coordinate your care across the different physicians and specialists that are going to be involved in your care. They're also the ones that are working with the discharge planners to start thinking about how and what time they're going to be able to get you out of the hospital. So keeping all of that straight and keeping that communication straight is challenging. That's why it's always good to have your point of contact on the phone and to take the time to ask questions. You also have the right as a patient in the hospital to always speak with your doctor. If that doctor came by and rounded when you were asleep and you didn't get a chance to talk to them and you have questions, you can ask the nurse to page the physician for you. They may not be available at that time, but ask them to give you a time when they are available that they might be able to call you or come to your room. That's also true for your family members. So this whole thing about family members having to get up at 5 o'clock and go to the hospital and wait for the physician to round isn't necessarily what you always have to do. You can put a note on the chart, and the nurses are good about this. If your family member wants to talk to somebody, they'll put a note on there, and when that doctor's rounding, they're going to say, hey, Dr. Smith, you know, Barbara's son really wants to speak with you about how she's doing right now. He hasn't been able to see her in person, and he has some questions about her surgery. So that's something that can happen, and it's not unreasonable for you to ask for that. So that's kind of the end of my presentation. The next slide I have here is just some websites you can go to, and I'll get this information to Jane so that she can share it with you. And then the last thing I'll share with you, this is a quick little profile that we care weavers built out just as a 2-page little document to get you to write down your medications, as well as, you know, a little bit about who you are, who's your healthcare power of attorney, what allergies do you have, and what kind of chronic disease conditions might you have. So if you don't have a short little bio, this one will come in handy, and you can just fill it out and hang it on your refrigerator.
That's amazing. That's really helpful because sometimes you go in and, you know, they don't know what you have going on.
Right.
Particularly the ER too.
Mm-hmm, mm-hmm.
I guess the ER is a whole nother story when you go in there, because that's another crazy experience.
It's pretty chaotic, yeah. And the other thing too, and you may also be aware that Atrium and Novant both now publish their waiting times for their emergency departments. If you're having a true emergency, it's not going to matter what the wait time is, because you just need to go if it's truly an emergency. But if it's like an urgent care situation, you may want to look at the wait times at the urgent cares and the emergency rooms and pick the one that has the lowest one, particularly if it's something that is not technically complex. I wouldn't suggest you do that if you think you're having a heart attack, but if you need stitches, or if you've got a sore throat that isn't getting better, or you have persistent headache that needs to be treated, you can go to what I call a lower acuity hospital and maybe have a lesser wait time with the same kind of result and outcome.
Can they now look at look at the notes, the different, and can they look at notes from, let's say, Atrium to Novant? Can they see, is it all now meshed so they can see it?
It is. There is interconnectivity. I wouldn't call it meshed. It's not necessarily a streamlined process, but Atrium and Novant have the ability to share information with one another. I don't know, and I have to say, Jane, now that you mentioned that, I haven't seen that in anyone's record. It could be due to the fact that the clients I'm working with only get care at one system versus another. But I'll have to think about it and maybe see if I do have a client that sees maybe someone at Novant as well as Atrium, just to
Well, I
see.
guess it's when you kind of go to the ER or urgent care, whether they have the ability, if it's not in the same system, if you kind of
Yeah.
cross that way.
Yeah, my recommendation is if you like the healthcare system that you're with, and you have an event, I always recommend that you try to stay with the same healthcare system, just for that main reason, because they have all that information at their fingertips, or they should. We ideally should have it across those systems, and it should all be displayed in a way that makes sense to the physician. But frankly, Novant uses a different software manufacturer than Atrium does. So even if they can pull records into another healthcare system, they may not be easy to search. It may just be like a blob of information, and you have to kind of page through each page of it. So it may not necessarily come up to them at the point of care and make it easy for the doctor to see maybe what's taken place in the past.
So if you're caring, if your loved one's in the hospital, so I hear you say it's possible, but can you really actually talk to the doctor? I mean, if you're not there for their rounds, so, I mean, is that really happening?
Yes.
Good.
You have to be persistent. I mean, call the nurse and say, look, I cannot visit. I want to be involved. Either when if your schedule permits you that the nurse can call you when the doc's in the room, that's great. But if you have a window of opportunity because you're working, you can say, look, I do want to talk to the physician. Unfortunately, these are the only hours I have available. Is it possible for you to get that message to the physician? And if you don't get a response back on that, you can escalate it. You can escalate it to the group. All of the people that are considered hospitalists, those folks that kind of coordinate the different physicians, they all work directly for the healthcare system. So they are employed by Novant and Atrium. So if you're not getting what you need from a hospitalist, I consider them an employee of the hospital. You can escalate that up to administration and say, look, I've tried now twice to get to talk to the hospitalist, and I can't get them to call me. Who do I need to reach out to make that happen? And I guarantee you'll get a result.
That's a nice change.
Yes, yes. And it's not unreasonable. They're there. You're hiring them. They are there to provide services to you. And if you're not getting what you need, either from the hospitalist or any physician involved in your care, it is certainly within your rights as a patient to request another physician to provide care for you. Always.
Do portals work the same way in this environment or no?
They do. Right now, like I have a client in the hospital right now, and I can go into their healthcare portal and I can see all their lab results for today. What I can't see until they're discharged is any of the physician's notes, or any of the, some of the radiology exams they do. They don't make them available until the patient's been discharged. But if you want those results, it's perfectly within your right as a patient or next of kin healthcare power of attorney to say, well, what was the result of the CAT scan? Did it show anything or not? And understand kind of where are we now in terms of either diagnosis or treatment, and how far out are we from discharge planning? You know, that those are all very reasonable questions to ask the doctor.
And who's allowed in now? I know that things have changed a little bit, right? If
You know what? It's so dependent upon the hospital and the patient's current condition and the floor that they're on that I really can't say. It's a matter of asking. I had a client that was at home under hospice care that had to go back into the hospital. And before the daughter decided where she was going to go, we called all the emergency departments for the system that they were in and asked them, because she had dementia, are you allowing somebody from the family to be with somebody who has dementia? And that was how she made her decision.
Interesting.
Yeah.
Well, that's good to know that some are, and so it's not universal. So you have to shop it, I guess.
You do. You kind of have to figure it out and ask, and then they'll tell you what they're able to do. I think in most cases, we're seeing hospitals loosen up their visiting restrictions. They are going to limit you to one visitor at a time. They're not going to let you kind of camp out in the room overnight and stay there continuously unless like there's a condition of dementia or someone is cognitively impaired and they can't speak for themselves. But they don't want a bunch of different people in and out. So if you're that person for that day, you're going to be that person for that day. You know, you can't change it out with your kids or your husband. They're trying to prevent the flow of traffic from the outside and the number of people that get introduced from the outside.
Makes sense. Okay. Great. Does anybody have any other questions for Cindy? This is great information. It's great to sort of think through these things before you're in a crisis mode too. So
Cindy, I just think your presentations, this is the second one I've heard that you've done, and I think they've been outstanding. I wish I had those before I dealt with incidents. So I have my notes here and I have your number. But I think one of the real problems that we ran into was the communication issues thing. And that anytime there was a real concern, and some of them could have been major, you know, I mean, it's kind of almost scary. And I think more in routine things, I did find I was diagnosed with cancer and had a couple of surgeries, and I didn't have any problems at all with the communication or anything. I had unbelievable care. But I think it's also programmed a little differently. None of it's emergency usually. You know, it's crisis in a critical sense, but and then my husband had a bad accident and then it became complicated, and it was much harder to get information or the right person or the right thing. But the other thing I don't know, Jane, if this might be a topic at some point or if this is something you deal with. One of the things that I think is also hard is if you have a situation, and I'm not even talking about a hospice or where a person's coming home that's terminal or anything, where a person is either coming home or having to go to rehab type follow-up care, that the communications and what to ask for there and what's allowed and how they're placed, I think that's a topic that people our age, I find around me, are really, there's a lot of confusion about. Does that make sense, Jane?
Yeah, it makes sense, but Cynthia, you tell me whether that's something you could address as a topic.
Sure, I would probably call it a transition in care, and there's multiple transitions in care.
Right.
Anytime that you have a transition in care, it's dangerous because you are moving from one type of care to another type of care, and that's when things get missed, dropped, errors get made, something gets left out, etc. So it could be something as simple as your discharge. You know, making sure that before you get discharged, you have everything lined up in your home that you need to be successful. If you have to go to a rehab, typically what happens, and this is true, if you have a knee replacement, you have to go to rehab. They're going to walk in there 2 days before your discharge or a day and say, here's a list of short-term rehabs you can go to, pick one.
Yeah.
That's what they give you. No other information. So you're totally unprepared.
We went through that. Yes.
Yeah. Yeah, you don't know what you're picking. That CMS.gov, that CMS Compare site, those rehabs will be listed out there where you can go in and you can look at the short-term rehab and the outcomes. Yeah, anything like that is fraught with potential for error or
And
oversight.
just being able to know the questions or that that's what it is, because if you've never been in a situation like that before, when somebody tells you you've got to decide by 6 o'clock where your partner is going in the morning to be moved, that they need to know by 6 o'clock and it's 2 o'clock in the afternoon, you can go look at this list of places is what they tell you, and you're like, wait a minute, if you're at least prepared to know you're going to have to do that. I think that I was fortunate in the fact that I had done some research anticipating this coming, but I do know from talking to people that that's a difficult thing in the communication with home health care and the doctors
Exactly.
is a big piece.
One of the things that we help people a lot with, particularly right now with COVID, because a lot of folks who maybe would have normally gone to a short-term rehab are opting not to do that just because of the visiting restrictions and the fact that you have to quarantine. So we've been heavily involved with a lot of clients setting up what we call short-term rehab in their homes, which is home health care, speech and physical therapy, occupational therapy, a visiting nurse, equipment, a doctor that can come and see you, or you can get to the doctor. So we've been heavily involved in managing all those logistics for people.
Well, I'm keeping your number handy because all these things are not what you expect, don't happen when you expect them.
Yeah.
But
Well,
I appreciate-
I think that topics, because people, I can't tell you since I've been back at the Y, how many people have, come up to me and said they were having something done and they're, who do you know, how, for that next phase of I'm by myself, who do you know? And because you're on your own when that stuff happens. So.
Right, that stuff thing. But thank you, Cindy. That's very valuable
Sure.
information. Thank you for sharing your time with us.
Mhm.
Yes, absolutely. Pinky, did you have something you wanted to add?
If you're having something like a knee replacement, you're going to rehab and you can make your arrangements ahead of time. That's what I did when I had my knee replacement. You
Yeah.
can also do your homework and
Right.
research some of the rehab places, sort of a just in case kind of thing.
Mm-hmm. You're
So
right.
it's our responsibility to look ahead as best we can if we think we're gonna, if you have a knee or hip replacement, you're gonna have rehab. So look ahead and make your arrangements.
Yep, you're right. We're going to recruit you as an advocate, Pinky.
I have already been one. Thank you.
Good for you. Any other questions?
No. Well, Cindy, this has been great. I mean, great information. I like I said, I'm a big believer in, there's a vast amount of things that can happen out there, and if you're prepared, a lot of times you can mitigate a lot of unfortunate things. So, thank you for raising awareness to what we need to be thinking and planning. There's so many people who, kind of live in the moment, and from a yoga standpoint, that's all fine and good, but not in this case. So
That's right. That's
it's great.
Well, I had told Jane that I might not be able to watch this program because I'm recently widowed, but it was very informative and I appreciate the information.
okay. Thank you. I'm glad you could join us.
Yeah, we're really happy to have you, and you guys continue to share great information. And if those guys that are watching this later, if you haven't seen the previous programming that we did earlier in March about how to be your own healthcare advocate, or if you haven't seen that lately, because sometimes we hear these things and then it's not relevant at the time, so it doesn't really click in. But you want to just continue to keep this stuff churning in the back of your head so you can be prepared and be your own best healthcare advocate. So thank you for being here for us, Cindy. And Cindy will send me some of the things she mentioned. Feel free to reach out to me, or I can put it out to the group. But just reach out to me via email, jane.hoagland@ymcacharlotte.org. And I send out weekly emails about programming. And if you want to be on that email list, don't hesitate to reach out to me and I can add you. So thanks again, Cindy. We appreciate you. And it's good to see everybody. I hope you take care. And spring is coming. Let's
Yes.
fingers
Yes.
crossed.
Take care,
Thank you very
everybody.
much.
Have a good
Thank you,
afternoon.
Cindy and Tony.
Thank you, everyone.
Yeah.
Bye.